Hello, my name is Doug Morse. I'm with a company called No Stress Training, where we do training for medical professionals, such as certification training in ACLS, PALS, CPR. We teach EKG recognition. We teach 12-lead interpretation courses. And today we're going to have a discussion about pediatric septic shock. Along with this presentation, you should have also received a digital copy of a handout that accompanies this that has most of this material already written down for you. Septic shock is a serious problem, and we confront it nearly daily in the intensive care units across the nation. The CDC tells us that sepsis occurs over 1 million times a year, and in those cases, over 250,000 people will ultimately die from this very serious and pervasive problem. The pathophysiology of sepsis is fairly straightforward. Under normal circumstances, an infection enters the body, and the body mobilizes defenses to find, flag, kill, and remove the infectious agent, and it does so without any outward signs at all. However, on occasion, an infectious agent is able to enter the body and overwhelm the body's immune system response, and that happens for two general reasons. The first reason is that the infectious agent itself is so virulent and so strong and so dangerous that the body doesn't have the resources to cope with it. In the second case, an infectious agent that is relatively routine and normally benign encounters an immune system that is weakened. Reasons for your immune system to be weakened could be comorbidities, the fact that the patient is taking immunosuppressive medications like with organ transplants or chemotherapy, or if the patient has intrinsic immune system dysregulation, for example, in a geriatric patient. In normal physiology, your vasculature carries healthy red blood cells laden with oxygen to distal tissues for distal tissues to engage in cellular respiration. But when an infection enters the picture, that circulatory mechanism is altered. The presence of the infectious agent is going to cause mobilization of white blood cells. And those white blood cells will migrate to just the local area of the infectious invasion and release vasoactive and cell-activating enzymes and chemicals in order to cause a cascade of reactions. One of those cascading reactions is the recruitment of additional white blood cells and immune system components. In addition to that, you see local vasodilation of vessels in just that local area of the infection. That vasodilation slows blood flow locally, increases the operating area within the vasculature, and also decreases blood flow velocity. All of these actions are designed to encourage the migration of immune system components. And then, because the infectious agent is probably not in the vasculature but in the extravascular area, the cells increase their permeability and allow movement across the cell membranes of the vascular wall for the purposes of combating this infection and removing it from the body. Now, that localized reaction is very helpful, and it allows white blood cells and immune system components to do their job cleanly and effectively. This only becomes a problem if that localized reaction begins to spread, eventually becoming widespread and systemic. When that localized response becomes widespread, it causes immediate problems. Localized vasodilation becomes pervasive systemic vasodilation. Localized permeability becomes pervasive and systemic permeability. This localized engagement of the immune system is now spread throughout the entire body, and the vascular space gets enormous. Permeability allows the leakage of fluids from the vasculature. The combination of increased vascular volume and permeability produces hypotension and distributive shock. So now your patient has distributive shock caused by vasodilation and increased permeability. Well, add to that an additional problem. All of that fluid leaking from the vasculature migrates out to the extravascular tissue, and that extra fluid increases perfusion distances from the oxygen-carrying blood cells to the body's distal cells requiring access to that oxygen. And that extra perfusion distance interferes with oxygen and gas exchange at the cellular level, and cellular respiration suffers. As cellular respiration suffers, you begin to see the onset of cellular ischemia and anaerobic metabolism. With anaerobic metabolism, you're going to get increased CO2 production, lactic acid, and the potential for mixed respiratory and metabolic acidosis. So this patient who's already suffering from distributive shock and cellular ischemia has additional compounding problems as well. The phagocytes, the component of the immune system responsible for attacking and destroying the infectious agents, begins to have this systemic body-wide confusion, and they lose the ability to tell friend from foe. And instead of just attacking infectious agents, they begin to attack healthy tissue as well, including the tissues that make up the vasculature. So phagocytosis begins to damage the patient's vasculature, causing these microhemorrhages systemically throughout the body. Now, this systemic microhemorrhage initiates the cascade of events seen in the coagulation response. Now, coagulation, when occurs in a small local area of loss of vascular integrity, is helpful in plugging that hole. But when coagulation occurs systemically from head to toe, there's a real problem with that. One problem is the fact is that you only have so many of these coagulation factors, and they become exhausted pretty quickly. In addition to that, the derangement of the coagulation system produces coagulation and clots in areas that are not appropriate, for example, within your circulating vasculature. When you have this combination of microhemorrhage and the development of clots within the vasculature itself, then you've got disseminated intravascular coagulation, or DIC. So your patient who has already suffered from hypotension and distributive shock, cellular ischemia, deranged phagocytosis and damage to body tissue, increased leakiness, deranged coagulation, now they have an additional problem. As this damage spreads to the pulmonary system, it begins to affect the lungs profoundly. You'll see thickening of the alveolar sacs and migration of fluid into the alveolar air spaces. And when this happens, that initiates the onset of acute respiratory distress syndrome, or ARDS. The combination of all of these factors complicating an overwhelming infection can go to illustrate why this disease process has such a high mortality. The mortality rate associated with septic shock in various studies over the last 10 years have ranged anywhere from 24 to 41% and are represented by mortality due to distributive shock, cardiovascular dysfunction, systemic ischemia, and anaerobic metabolism associated with metabolic and respiratory acidosis, coagulation disorders like DIC, and ARDS. Assuming that the onset of septic shock is occurring in a person who is otherwise relatively healthy, then you can see early strong cardiac compensation. That strong cardiac compensation is the result of alpha and beta adrenergic stimulation that occurs as the patient senses loss of vascular resistance. So what happens is that the distributive shock sets in, there's a loss of vascular tone, and then alpha and beta components kick in to increase inotropy, which is myocardial contractile strength, and chronotropy, which is heart rate. The combined increase in inotropy and chronotropy produces an enormous spike in cardiac output. That cardiac output then factors in against the decreased systemic vascular resistance to maintain a relatively decent blood pressure, but with a decrease in diastolic BP. The systemic vascular resistance causes the preload diastolic BP to drop, and you end up with the finding of wide pulse pressures. During this hyperdynamic cardiac compensation phase, the patient is in warm sepsis, and you'll see instantaneous capillary refill times, flash capillary refill times, bounding pulses, and warm ischemia. But this compensation can't last forever. These compensation factors will fatigue, resources will be exhausted, and the distributive shock will overcome the heart's ability to compensate. When that happens, adrenergic stimulation becomes inadequate, and as cardiac output drops as this compensatory mechanism fails, that compounds against a decrease in systemic vascular resistance, and your blood pressure just falls off of a cliff. And you see dramatic decreases in both systemic and diastolic blood pressure. These patients are in cold sepsis, and they present with cold extremities and extreme hypotension. The septic response occurs along a continuum that runs from relatively mild to deadly. On the mild side, you have SIRS, or Systemic Inflammatory Response Syndrome. And as you acquire a known infection with findings of SIRS, you have sepsis. And then as you have cardiac dysfunction in sepsis, you move into septic shock. And then finally, at the end of the spectrum, as multiple organ systems begin to fail, you have MODS, or Multiple Organ Dysfunction Syndrome. We're going to talk about each of these in turn. Pediatric SIRS is an assessment tool used to identify patients at risk because of infections. It's got 4 criteria, and to qualify as positive on this scale, you have to satisfy 2 of the 4, but one of the 2 qualifying criteria has got to be either temperature or white blood cell derangement, the 2 components that you see on this slide that have asterisks in front of them. Each of the 4 possible criteria for qualification include a heart rate above 2 standard deviations, or approximately 95th percentile above norm for that child's age, or if they're an infant, if they're bradycardic. Secondly, a respiratory rate that's greater than 2 standard deviations, or approximately 95th percentile above norm for the child's age, or a child who requires mechanical ventilation in order to breathe. The third criteria is a core temp that is above 101.3 or below 96.8. And then finally, white blood cell derangement, and that could be increased or decreased based on whether the body is ramping up for an infection or becoming exhausted by an infection that is unrelated to chemotherapy, or a white blood cell differential that demonstrates that greater than 10% of the white blood cells are immature neutrophils or band cells. This indicates that the immune system is being stressed and is releasing these immature neutrophils before it's ready in order to be able to fight the infection. Continuing down the infection spectrum, we come next to sepsis. Sepsis is identified as a patient who has qualified as positive on the SIRS assessment tool and has a confirmed systemic bloodborne infection. The SIRS patient is represented on this Venn diagram with the bluish circle on the right. And it's interesting here to note that SIRS can be triggered through trauma, burns, pancreatitis, and other mechanisms besides an infection. But when infection due to bacterial, fungi, parasite, viral, or other infectious agents is the causative agent for the SIRS, and the infection and the SIRS overlap, that's the definition of sepsis. Moving further down the continuum, we take a patient who has sepsis and we add to that myocardial dysfunction. That's septic shock. Sepsis with cardiovascular dysfunction that persists despite 40 or more milliliters per hour of an isotonic crystalloid solution like normal saline within the first hour. Now, how do you define cardiovascular dysfunction? That can be defined as either hypotension or in a patient who has to rely upon vasoactive medications to maintain their blood pressure. Or if the patient, especially pediatric patients, have at least two of the following criteria: extra long capillary refill of greater than 2 seconds, oliguria indicating kidney dysfunction, metabolic acidosis, or increased arterial lactate. And the two findings there together, the metabolic acidosis and the increased serum lactate, would indicate lactic acidosis. Another way to look at or define septic shock is that it's a clinical syndrome complicating severe infection that's characterized by systemic inflammation, immune system dysregulation, microcirculatory derangement like DIC, and end organ dysfunction. At the very end of the continuum is the category of patients with the highest level of mortality, and that's patients that experience multiple organ system failure. MODS is multiple organ dysfunction syndrome, and we grade for this and we guard against this with certain assessment tools. One of those assessment tools is the sequential organ failure assessment score, and this is a mortality prediction score that's based on 6 different organ systems and measurements of organ system health. And this slide outlines who should get SOFA scoring and under what conditions. There's a copy of the SOFA score in your digital handout, and you can review this material, and it's used extensively in ICUs in patients with septic shock to try to keep people from reaching this end of the continuum. The most important thing that we can do to reduce morbidity and mortality due to septic shock is rapid recognition and rapid initiation of aggressive treatment. Now, this can be a little harder than it seems on the surface, because the patient who walks in with septic shock doesn't sign in with septic shock. They're going to sign in with a UTI or with pneumonia or with signs related to meningitis or a gut infection. And it's easy to get tunnel visioned into those individual presentations and to lose sight of the larger picture, the fact that this patient is at risk for sepsis and septic shock. For that reason, experts recommend that we use standardized recognition bundles that are built into our electronic patient record systems. As you enter a patient's vital signs and clinical presentation data, certain findings will pull the trigger to alert you of the danger of septic shock with that patient. Now, these standard recognition bundles admittedly throw a wide net, and you may gather in a bunch of false positives, and that's okay. It's much better to have a bunch of false positives than it is to let one single septic patient have their treatment delayed by an hour or more, which vastly increases mortality. Missing one of these septic shock patients is not okay. Once the patient is recognized through clinical presentation or these standardized recognition bundles, they should be assessed face-to-face, hands-on by a physician or a mid-level within 15 minutes. And then upon the recognition that the patient is a probable sepsis patient, resuscitation treatment should be begun within 15 minutes of that recognition. Now, as a final note, don't rely on hypotension to be a finding for septic shock, especially in children. Children have miraculous compensatory mechanisms, and they can shunt blood to the nth degree, and they will shut off parts of their cardiovascular system in order to maintain decent central systolic blood pressure. So don't rely on hypotension to diagnose septic shock in children. The following is a list of potential red flag criteria that could trip some of these recognition bundles. And this list is by no means inclusive. This is just an example. Fever, hypothermia, tachycardia, tachypnea, abnormal pulse qualities, slow capillary refill times, hypotension, altered mental status, purpura or petechiae, and macular erythema with mucosal changes like strawberry tongue, eye infections, macular erythema. And there's some examples of what those can look like. Additional signs of infection include a child who just doesn't look like they feel well, a toxic or ill appearance. It's one of the foundational principles in PALS that a sick kid usually looks sick. Signs of dehydration, rigors, which is shaking or chills, probably due to fever, and decreased muscle tone in neonates and infants. Seizures, signs that could indicate the presence of meningitis like nuchal rigidity or a positive Koenig sign. That's where you lift the hip and knee to 90 degrees and then attempt to straighten the leg, and that stretching of the meningeal membranes produces intense pain, and often the patient's head will come up off of the stretcher in response to that. Respiratory depression, respiratory failure, pulmonary rales, or decreased breath sounds caused by bronchopneumonia. A distended tender abdomen like you see in peritonitis. Costovertebral angle tenderness, which is a percussion over the kidneys that it can indicate kidney infection. Macular erythema, cellulitis, abscess. Warmth and swelling and redness of an extremity, peripheral edema, nodular lymphangitis, eczema associated with Pseudomonas infections, and you see a picture of that there, and pyuria suggestive of pus in a urine sample. It's important to draw labs early. Bedside glucose is especially important, and we need to be assessing that on a serial basis. Even a child with no history of diabetes can become hypoglycemic as they exhaust resources attempting to compensate for the effects of an infection. Arterial or venous blood gases, complete blood count with differential so you can watch those band cells and so you can watch your white blood cells. Serum lactate. Serum lactate is used to gauge the degree of anaerobic metabolism and the potential danger of lactic acidosis. BUM and serum creatinine to watch kidney function. Ionized blood calcium is an important lab value. Septic shock can cause hypocalcemia through hyperactivation of parathyroid function. And if your patient becomes hypocalcemic, you're going to have to treat that, probably with calcium gluconate. And then watch your bilirubins and ALT functions to keep an eye on the liver. Your clotting factors, your PT, PTT, INR, fibrinogen, and D-dimers. You're going to want to pull blood cultures. If you do have a bacterial infection in the blood, you're going to pull a culture, and then when those culture results come back, you may adjust your broad spectrum empiric antibiotic therapy to be more fitting to whatever that culture grew out. Urinalysis and urine culture, if you think that the infection is from the kidney and the urinary system, and then any other tests and cultures suggested by patient presentation. So for example, if your patient did present with neck rigidity and a positive Kiernig sign, then you probably want to get a lumbar puncture. Some common lab abnormalities that you may see in your pediatrics. If you've got ABGs that indicate acidosis, especially metabolic acidosis, and you have elevated serum lactates, then you probably have got lactic acidosis. Leukocytosis or leukopenia, which is an increase or decrease in your white blood cells caused by activation of the immune system. Declined platelet counts and decreased clotting factors that are associated with the formation of DIC. Increased creatinine suggestive of renal insufficiency, and increased bilirubin suggestive of liver dysfunction. When you recognize that your patient is at risk for warm or cold septic shock, you must begin resuscitation immediately. Time is of the essence. The objectives for initial resuscitation should be accomplished within the first 60 minutes of diagnosis, and the primary goals include restoration of hemodynamic stability, support of related organ system functions, and then identification and treatment of the underlying causative infection. Resuscitation actions should include at least the following. Get immediate IV or intraosseous access, preferably large bore and preferably more than one access. Begin fluid resuscitation right away, and typically you're going to start that with a crystalloid isotonic solution like Ringer's or normal saline. Go ahead and get your labs, especially your blood cultures. Blood cultures should be drawn before you begin broad-spectrum empiric antibiotics, because if you draw that lab culture and antibiotics are contaminating the sample, then that's going to change the way the sample grows out in the lab. Begin broad-spectrum antibiotics right away. If there is a delay in getting certain cultures, say for example cerebrospinal fluid culture, don't delay the antibiotics for that culture. It's best to get the cultures before you begin antibiotics, but antibiotics should be begun within the first hour. Delays in antibiotic therapy produces big spikes in eventual mortality from septic shock. If within the first hour the patient doesn't respond well to fluids, if they have fluid refractory shock, then we should begin inotropic and vasoactive infusions, and then consider antipyretics. The treatment of fever in an infection is designed for patient comfort, not to abolish fever. Often fever is a helpful part of the immune system response, and so pediatricians will frequently let a fever ride, but if the fever is making the patient miserable, then consider treatment. Therapeutic endpoints. This is our goal. They include improved central and peripheral pulse qualities, improved skin perfusion, which is a capillary refill time of less than 2 seconds, an improved mental status, improved urine output, 1 or more milliliters per kilogram per hour, systolic blood pressure that matches at least 5th percentile per age. And for infants less than 1 month old, that's a systolic of 60. For kids older than 10, that's a 90. And from kids between 1 month and 10, we'll use the PALS formula of 70 plus 2 times their age in years. Improved serum lactate to show a switch from anaerobic back to aerobic metabolism, and then central venous O2 saturations greater than or equal to 70%. Airway and breathing are supported with oxygen, intubation, and mechanical ventilation as necessary. Initially, the patient should receive 100% oxygen to combat cellular ischemia. But once normal perfusion is restored, once good peripheral circulatory signs have been restored, then oxygen should be titrated back to a pulse ox of 94 to 99% to avoid oxygen-related tissue injury, which is prevalent in children. Endotracheal intubation may be required to maintain a patient's airway, but even if it isn't required, sometimes the clinician will do an intubation simply to give the body a break. In septic shock, up to 40% of your cardiac output is devoted to respiratory function. And by intubating a patient and putting them on mechanical ventilation, you decrease some of that strain. If you are intubating a child in septic shock, there are certain complications and challenges that you have to be aware of when you do rapid sequence induction or rapid sequence intubation. If your patient has unstable hemodynamics, we need to do everything we can to stabilize that before giving RSI medications, which are often adversely affect hemodynamic function. You should consider pre-treatment with atropine. As we're rooting around in the airway, you could cause vagal-related bradycardias. Typically, you do not want to use etomidate in an RSI protocol with septic shock in kids. You prefer ketamine. That etomidate is not recommended because it can inhibit cortisol formation. Propofol is not generally recommended in this situation because it can induce or exacerbate hypotension. Ketamine is the sedative of choice as long as your child is above 3 months old and as long as they don't have a history of psychosis. And then be aware that you're intubating children with less than 5.0 tubes, typically with an uncuffed ET tube, and you have to have precise sizing for that. Circulatory support is critical. If you can get 2 large bore IVs very quickly, then go with that. If you can't, then use IO. There's a picture there of the EZ-IO, which is a technology which allows us to very rapidly gain access with an interosseous needle in the tibia, the iliac crest, the humerus, a whole number of different sites that can be used for fluid resuscitation. You're going to want to start fluid resuscitation immediately with 20 cc's per kilogram of an isotonic crystalloid solution like Ringer's or saline, and you're going to push that over about 5 minutes. If you have neonates or children with pre-existing cardiovascular compromise, you're going to reduce that bolus down to 10 cc's per kilogram, and you may push it a little bit slower than 5 minutes in order to gauge whether the fluids are helping or hurting as you're giving these boluses. When you're giving these 20 cc per kilogram rapid boluses to a child, you're going to do precise dosing, probably by using a 3-way stopcock to draw the fluid from the bag and then push it into the child in that precise dose. Each time you give a fluid bolus to a child, reassess their vital signs in clinical presentation for signs of improvement, meaning that we're reaching some of those treatment endpoints, or deterioration caused by excess fluid. Some of these kids, because they're so massively vasodilated, can require 1, 2, 3, and even 4 of these 20 cc per kilogram boluses within the first hour. But you have to be very careful about overloading them with fluid. One of the signs that you'll see with an overload of fluid is formation of wet breath sounds, rales, respiratory distress, and potentially following that you could see swelling of the liver or hepatomegaly. If patients don't respond well to that initial hour's worth of fluid boluses, then you do need to switch to inotropic or vasoactive medications. These are going to be infusions that are chosen for the child based on their age, weight, BP, and clinical presentations, and we're going to find what the recommendations are for those medications from the septic shock protocol in just a few minutes. Once you've achieved hemodynamic stability and effective circulating volume, then you back off on the aggressiveness with the fluids and just have maintenance fluids going. Carefully assessing and reassessing labs, vital signs, urine output, and doing central and/or arterial hemodynamic monitoring. We mentioned earlier how easy it is for a child to develop hypoglycemia as their body is engaged in this battle against this infection. keep a close eye on their blood sugar and administer D10, D25, or D50 as appropriate for the child's age to maintain blood glucose between 70 and 150, and continue to monitor their other electrolytes, especially calcium, as you see that parathyroid function consuming available intrinsic calcium. Broad-spectrum empiric antibiotics are indicated within the first hour of treatment, preferably after getting relevant cultures. As we said earlier, however, if some of the cultures are presenting you with difficulties, don't delay empiric antibiotic therapy in order to get the cultures. Each hour of delay in antibiotic therapy equates to an 8% increase in mortality in recent adult studies. This is just an example of some of those broad-spectrum antibiotics that could be considered: Rocephin, Zithromax, Cipro, vancomycin, and penicillin derivatives. The choice of antimicrobial can be a complicated decision, and it's highly recommended that you consult with an expert in pediatric infectious diseases when you make this decision. Most kids with septic shock should get MRSA coverage in their antibiotics, and children should have enteric organisms considered whenever there are GI or GU sources of the infection. Children who are already immunosuppressed or at risk for infection should get treatment for Pseudomonas coverage. And in kids less than 28 days old, recognize the danger of listeria and herpes simplex virus contagion. When it comes down to your final choice of antibiotic, if you have more than one option available, always choose the antibiotic that can be given faster. An antibiotic that can be introduced into the bloodstream quicker is best in this situation. And then finally, as you get cultures come back from the labs, be prepared to adjust your antimicrobial therapy to the gram findings of your cultures to have the most effective antibiotic in place. All right, there's a couple of different prognosis pathways that we can see within this first hour of initial resuscitation. Best possible outcome is that the shock resolves and you're just dealing now with an uncomplicated infection. If that's the case, continue observation and consider critical care consultation. A second clinical pathway is that the shock persists and is not resolved by our initial 1 hour aggressive therapy. That child will need to be moved into the critical care environment. So get a critical care consultation and begin and titrate vasoactive and inotropic medications based on whether the child is in cold or warm sepsis. Cold sepsis is recognized because the child has cold extremities, delayed capillary refill, and systolic hypotension. The vasoactive infusion of choice for that child is epinephrine. If epinephrine is not available, you can use dopamine. The child in warm sepsis is recognized because despite poor perfusion, they have flash capillary refill, hyperdynamic cardiac output numbers, and diastolic hypotension. For that child, the inotropic infusion of choice is norepinephrine. If norepinephrine is not available, again, you can use dopamine in its place, but you'll probably be using higher doses. The PALS curriculum sums up the choice of inotropic infusions for the child who's fluid refractory like this. If the child is normotensive, then they're just going to get dopamine as a supportive measure. It's going to be titrated to blood pressure and hemodynamic response. If they're in warm sepsis, they're going to get norepinephrine. If they're in cold sepsis, they're going to get epi. And these are all vasoactive infusions given in an age and weight appropriate dose. In addition to vasoactive and inotropic infusions, the child should also get central and or intra-arterial monitoring, continued infusions and fluid boluses titrated to their clinical response, constant monitoring and correction of problems with the airway, breathing, and circulation, and then evaluation of their steroids, cortisol, and you may have to consider stress dose hydrocortisone. Do this only with expert consultation. High dose hydrocortisone in this situation can be dangerous and should only be used when it's indicated. Additional details about continued critical care treatment of the cold sepsis patient according to PALS identifies the patient as having a central venous O2 sat of less than 70 and cold findings, cold extremities, poor perfusion, low systolic blood pressure, despite the fact that you've got an epi infusion going on in the patient. Titrate additional fluids as indicated. Consider transfusions if the patient's hemoglobin is low. Continue the epinephrine infusion, and if that does not provide improvement, then consider adding norepinephrine. If the blood pressure is adequate with the epinephrine, consider milrinone or other vasopressors. The septic shock protocol in PALS recommends the following additional actions for a patient with warm sepsis findings. And you'll recognize the warm patient because they'll have central venous O2 sats greater than 70 and warm extremities with that hyperdynamic cardiac output. Titrate additional fluid boluses, continue the norepinephrine infusion if it's helping, consider additional vasopressors or inotropic therapies as needed, and then support organ function. The PALS protocol for septic shock continues with discussing the child who has good central venous O2 sats and no shock. That patient should be monitored in the PICU until stable, support organ function, treat the infection source, and continued aggressive evaluations. I've also included the initial resuscitation algorithm from the Surviving Sepsis campaign. This algorithm mirrors the PALS algorithm and protocol for septic shock very closely. It too calls for aggressive treatment to begin within the first hour of recognition of septic shock. Its treatment points, the 6 red circles that you see in the middle of the page, mirror the PALS recommendations exactly. Get IV access, get blood cultures, start broad spectrum antibiotics, watch your lactate, start aggressive fluid boluses, and begin vasoactive agents if the child is fluid refractory. Below those treatment points, they point out the continuous reassessment cycle that never ends. The continuing assessment for pediatric acute respiratory distress syndrome, the titration of fluid to patient effect, advanced hemodynamic monitoring, and fighting the source of the infection. The second page of the Surviving Sepsis campaign breaks patient treatment systems into 2 different systems. The blue system on the left is what you're going to find most of the time in your first world countries. These are healthcare systems with intensive care, and that treatment algorithm mirrors the treatment algorithm in PALS almost exactly. What's interesting though is that on the right side, sort of the greenish area there, is healthcare systems without intensive care, and these recommendations came from studies that were done in sub-Saharan Africa where they did not have advanced medical care available, but they do have a large incidence of sepsis, and in those situations when you didn't have access to intubation and pulmonary support like mechanical ventilation, they found that the patients did worse if they got these big fluid boluses because of the complications associated with fluid. So you may see that in some of your literature, that if you're in a healthcare system that does not have access to intensive care, then they may back off on the fluids a little bit. All right, let's apply what we've learned into a couple of case studies here. The first case study, picture a 4-year-old little boy that's been resident in your PICU for a week recovering from some serious respiratory pathology. He's already intubated non-mechanical ventilation. He's got a central line that's being used for medication, sedation, and fluid administration. He's warm to touch and his breath sounds are clear. You take vital signs. You find a heart rate of 144. His mechanical ventilations produce a respiratory rate of 22. His blood pressure is 88/32, and his temperature is 102.2. His pulse ox, again, on 100% O2 and mechanical ventilation is 100%. And his central venous O2 sat is 76, and his CRTs are less than 1 second. They're very brisk. His blood glucose is 114. His lactate is 2.4, so it's high. And his white blood count is also high, with a particular spike in band cells, those immature neutrophils. Based on those findings, does this child meet the criteria for SIRS? And the answer is yes. He meets every single criteria. He's got a fever above 101.3. He's got a heart rate above 95th percentile. He's got a respiratory rate above 95th percentile, and he does have derangement of his white blood counts, including excess immature neutrophils. What clinical risk factors does this patient display that point towards sepsis? He's got several different risk factors that point to the potential for sepsis. For one thing, he's intubated and he's on mechanical ventilation and he's got a central line. The ET tube and the central line, especially if they've been resident for a little while, are enormous risk factors for the introduction of pathogens. He also, because he's been resident in the PICU and in the hospital for so long, has the potential for nosocomial exposures, iatrogenic exposures to infection. And then he's got the comorbidity of the past respiratory pathology that was unspecified but is part of his clinical picture. Does he show you any signs that indicate that he's in septic shock? And the answer is absolutely. The elevated heart rate, the wide pulse pressure that you saw with the very low diastolic blood pressure, the elevated temperature, the elevated lactate, and we're going to want to check his blood gases to make sure he doesn't develop metabolic and lactic acidosis, his elevated white blood cell count, including greater than 10% number in band cells. And the type of shock that he's displaying is warm shock, because he's got that peripheral vasodilation with the warm extremities, the hyperdynamic cardiac output, the wide pulse pressures, and the flash CRTs. What do we want to do for this 4-year-old little boy? Well, in the first hour, he's going to get repeated fluid boluses, 20 cc's per kilogram, once, twice, 3 times, maybe even 4 times within the first hour, with careful evaluation in between of his breath sounds, the state of his liver, and his hemodynamic response to the fluids. We're definitely going to get blood cultures, and because of the respiratory component, we may also get a sputum culture. We are going to start broad-spectrum antibiotics within the first hour of recognition of the symptoms. We're going to determine if whatever sedation agent he's on for his intubation is not causing problems with his blood pressure. Some sedation agents can exacerbate hypotension, and if that's the case, we may want to trade out that sedative. If the response to fluids is unsatisfactory within the first hour, we're going to start norepinephrine on him because he's got warm shock. We're going to do aggressive serial evaluations, and we're going to call in expert consultation. Case study number 2. We've got a 9-year-old girl in the emergency room with intense 10 out of 10 pain centered on her navel. Mom says she's had loss of appetite for a week with the development of nausea, vomiting, and diarrhea in the last 24 hours. Her vital signs are as follows. Her heart rate's 140, a respiratory rate of 34, a blood pressure of 104/42, her temperature is 100.4, pulse ox is 98% on room air, CRT is less than 1 second, and she has positive abdominal rebound tenderness over her right lower quadrant upon abdominal palpation. Her labs, her glucose is at 89, her lactate is 0.8, her white blood cell count shows elevated levels of white blood cells. Band cells are normal. Does she meet criteria for SIRS? And the answer is yes. She doesn't meet every criteria, but remember that for SIRS you only have to meet 2 out of 4 of the criteria as long as one of them is either temperature or derangement of white blood cells. And what she has is the elevated heart rate, the elevated respiratory rate, and the elevated white blood count. What signs is she showing that could indicate septic shock? She's got the elevated heart rate, she's got the wide pulse pressure with the low diastolic pressure. She doesn't have a temperature that qualifies her for SIRS criteria, but she does have a low-grade fever. She's got elevated white blood counts, and she's got positive diagnostic signs for potentially appendicitis. Her presentation is also warm septic shock. Peripheral vasodilation, warm peripheral extremities, wide pulse pressures, and flash CRTs. Treatment for her: fluid boluses of 20 cc's per kilogram up to 4 times, with assessment in between of her breath sounds, the state of her abdomen, and her clinical response to the fluids. We need to get an ultrasound on that belly. We need to have experts come in here and take a look at her appendix. Go ahead and draw blood cultures. Go ahead and do whatever tests that are required to rule out urinary tract infection and other conditions that can mimic appendicitis. Start broad spectrum antibiotics. And here's a key point that we haven't mentioned so far. Some infections are going to require more than just a medical intervention. This child needs a surgical consult, so that surgical consult should be called in within the first hour as well. If the response to fluids in that first hour is unsatisfactory because she's got warm shock, we'll consider a norepinephrine infusion, aggressive serial evaluations, and then continued expert consultation. Case number 3. We have a 2-year-old little girl, special needs child in PICU. She suffered a vomiting aspiration event a week ago and is currently under observation. She's been doing well, but today she was found with an acute obtunded level of consciousness and lethargy. Here are her vital signs. Her heart rate is 160, respiratory rate is 42, blood pressure is miserable at 52/30. She's got a fever of 102.9 and a pulse ox of 88. Her CRTs are delayed to 6 seconds. She's cool to touch and you auscultate bilateral rails. Her blood glucose is pretty low at 52. Her lactate is high at 3. You do have elevations in her white blood count. An ABG is available, which shows low to normal O2 at 79, high CO2 at 53, low pH at 7.22, indicating acidity, and a base excess of 1. She's got an ugly wet x-ray showing pulmonary lobar consolidation. Does she meet criteria for SIRS? Absolutely. She meets every single criteria for SIRS. Elevated temperature, elevated heart rate, elevated respiratory rate, and elevated white blood cell count. Does she have any clinical risk factors that point to the potential of sepsis? Her risk factors include the fact that she suffered an aspiration pneumonia, the fact that she's been in the hospital for a while and has had exposure to nosocomial infections, and then the potential comorbidity associated with her special needs presentation. Does she have any signs that indicate the potential for septic shock? Well, she's got the elevated heart rate. She's got systolic and diastolic hypertension. She's got a temp. She's got elevated lactate. Now, her blood gas was showing a mix of metabolic and or respiratory acidosis, and that's not uncommon because she does have the lactate producing the metabolic acidosis, and then she's got the pulmonary condition producing the respiratory acidosis. So they can produce some pretty complicated looking blood gases. She's got elevated white blood count, and she's got an ugly wet x-ray. Her type of sepsis is cold sepsis. She's gone past that compensatory stage, and now she is dropping into hypotensive septic shock, extremely dangerous. She's cool to touch, she's hypotensive, and she has delayed CRTs. The supportive treatment for this child is going to be a little bit more complicated. In our other case studies, we talked about aggressive fluid boluses repeated in the first hour to support cardiovascular function, but this little girl is already suffering wet breath sounds, a contraindication to fluid boluses. It's possible in this situation that you would defer the fluids and go straight to inotropic or vasoactive medications. If fluids were deemed necessary, they would not be given 20 cc's per kilogram and they would not be pushed rapidly. Instead, we would drop the dose to 10 cc's per kilogram, and they would be pushed much slower and with much more careful attention to the effect that it has on her breath sounds and cardiovascular system. You'll still want to get your sputum and blood cultures. You'll still want to start a broad-spectrum antibiotic as quickly as possible, but you're also going to want to move very quickly to intubation. This child is hypoxic. This child is suffering from cellular ischemia as indicated by her lactate levels, and we need to push oxygen through this fluid in her lungs, and we're going to do that with PEEP. Once she's intubated and once she is on mechanical ventilation, we can set positive and expiratory pressure to help facilitate oxygenation. We're going to use dextrose to treat hypoglycemia and get it back into normal range. And if her response to fluids is unsatisfactory or if fluids are deferred, we're going to move right to epinephrine as the infusion drug of choice because she's in cold sepsis. If epinephrine doesn't give us the blood pressure support that we're looking for, then we'll consider adding norepinephrine on top of the epinephrine. And we'll continue with aggressive serial evaluations and expert consultation. Finally, in summary, I want to go over some of the key points that we've discussed. The most important thing for a septic patient is early recognition and early aggressive treatment. The use of these electronic record-based recognition bundles will help us with early recognition and keep these patients from slipping past us and causing delays in treatment. When these patients are identified, within the first hour, they get lots of fluids, titrated to their weight and titrated to effect. Cultures and labs. Broad-spectrum antibiotics should be started within the first hour and then adjusted as culture results begin coming back. Reassess frequently not only their vital signs and clinical picture, but also their blood sugar and calcium. And use vasoactive and inotropic medications to support perfusion when fluids are not producing the results that you need. And then finally, support organ system function. Okay, that's it. I want to thank you for participating in this discussion and wish you luck out there, and I want to thank you for being there for our kids.